Hey, good morning. I'm Dr. Isabella Ramirez. Today I'm going to present a case about an atypical Guillain-Barre syndrome, also known as acute motor axonal neuropathy. If you have any questions throughout the presentation, please let me know so we can do this more interactive. So I'm going to start telling about the demographic area or demographic data of the patient. So our patient is going to be, we're going to call him AJ. He's a 56-year-old male patient and is an Hispanic patient. His current or previous job before the case or before his presentation, he was a constructor, and the marital status was he was married. He had 2 children, and he was very healthy. Otherwise, he didn't have any past medical history. So his chief complaint was, I have leg weakness. That's why I'm coming here to the office or to the hospital at that time. So this case was occurred on February of this year. So it's very recently. So Mr. AJ, is a 56-year-old male patient, otherwise healthy, that presented to Innova Hospital on February 17, 2025, due to one-day history of sudden onset of intense back pain associated with bilateral leg weakness, right arm weakness, and difficulty walking. 6 days before to this presentation, he had intermittent fever, chills, and dysuria, which was treated with cefuroxime by his primary medical doctor. However, he continued presenting those symptoms. The cefuroxime didn't help at all. He denied recent diarrhea episodes, nausea, emesis, syncope, falls, seizure events, or any other symptoms at that moment. The patient was, as I mentioned, was very healthy. He didn't smoke ever. He didn't drink alcohol, neither drugs, marijuana, nothing. He was very healthy. The physical examination, so we have at that moment when he went to the emergency room, because he presented to the Innova emergency room, the blood pressure was 141/93. The pulse was high, 115, so he was tachycardic. Respiratory normal. Temperature was high, so he was with fever. And the saturation of oxygen was normal. So all the systems, they made a very complete physical examination. It was very normal, except for this. The cranial nerves were intact. There was a notorious flaccid paralysis in all the extremities, lower limbs, upper limbs. Also, there was a reflexia of the deep tendon reflexes, but the Babinski wasn't present. And he prevents neck flexion, so it wasn't supple, the neck. All the muscles, the body, like the extremities, were flaccid, but at that time, he couldn't make any facial movement. So the muscles of the face were working properly. They weren't altered. So at that moment, doctors were thinking about what's going on, what are the possibilities or the differential diagnosis. So they thought about an ascending paralysis. They thought a bit about meningismus because of the neck, it wasn't supple. Osteomyelitis, because the patient has a previous dysuria symptom, so they thought that the principal source was the urinary tract infection that can cause an osteomyelitis or a spinal abscess. Also, at that age, could be a paraneoplastic disease. There are some paraneoplastic diseases that can affect the sensory and motor nerves. Could have also transverse myelitis in an upper level because he had an alteration of both upper and lower limbs. Also, they thought about a stroke, a cerebrovascular accident. And finally, they thought about an acute inflammatory demyelinating polyneuropathy, also known as Guillain-Barre syndrome, because they were because of the fever and like illness previous to this weakness. So they did some blood workout, a complete and exhausted blood workout, diagnostic exams. So at that moment, the glucose was pretty normal, was 130, was high, 136. But the other one, like basic metabolic profile, the complete was normal. So here, glomerular filtration rate was normal, the creatinine was normal, calcium, sodium were normal. The complete blood count showed that he has a leukocytosis with neutrophilia. So the white blood cell count was high, 14.2, and the neutrophils were also high. The platelet count, the hemoglobin were normal. So they started ruling out the conditions. So the SARS-CoV, it was not detected. RNA influenza A and B, like influenza A, influenza B, they were not detected. The creatine kinase, it was pretty normal, so they rule out a myopathy because it wasn't, the creatine kinase was normal. The urinalysis just was positive for a protein trace positive, mild, very mild. The C-reactive protein was high, 1.5. Sedimentation rate was high, 40. And also it was very interesting because the blood culture, sorry. Oh my gosh. The blood culture was a negative. Hepatitis, infectious disease were negative. The serum protein electrophoresis was normal, but the kappa line chain in blood was high, 1.95, but the lambda-like chain was normal. So I put on red, with red, the laboratory results that were normal. So you can like try to understand what I'm saying. They started thinking, okay, we have to see to make some images. So they thinking about the myelitis and everything that I mentioned before. So they made the lumbar MRI. The lumbar MRI was pretty normal. It didn't show no lumbar spine fracture, no evidence of an epidural abscess, no evidence of discitis or myelitis. The head MRI was positive for minor chronic small vessel ischemic changes that could be related to the age, but it wasn't like the cause of this quadriplegia. And also there was a small lesion in the right parietal bone, but it's like an accidental, it was an accidental finding. The chest X-ray, there was no intrathoracic process, and the CT of the chest, abdomen, and pelvis was pretty normal. They didn't detect any source of infection or mass or tumor, nothing. So they said, okay, let's do the CSF of the lumbar puncture. So let's extract some cerebrospinal fluid. We're going to do the lumbar puncture. They do a very complete examination of the CSF. The gram stain was negative, no bacteria, no culture positive. The oligoclonal bands were negative. The glucose was within the normal range, but the protein was a little bit high, 66. Also, the white blood cell count was high, 67. The red blood cell was positive, was high, with 12 red blood cells. The neutrophils also were high, 42, and lymphocytes, 29. The antibodies, anti-nuclear antibodies were negative. And so they start thinking about, so we have to do like more exhaustive or deep examination, or we're going to do some other test, because if We have some, like we have a pleocytosis, neutrophilic, CSF. So we have to see if it is not bacteria, what is the cause. So the positive, they were thinking about the Guillain-Barre syndrome because it's was because of the rapid onset of the weakness. So they we're looking at some antibodies, and the only positive antibodies that they found were the antibodies anti-GM1, anti-ganglioside M1. They were positive E1 in 16,000. The other antibodies against the other gangliosides, IgG, GQ, GD, were negative. Also, the antibodies IgM against the ganglioside M1 that were positive with the IgG, but the IgM were negative. So just the IgG was positive. The aquaporin 4 antibody IgG was negative, and the NMDA receptor antibody was negative. Just so far, we have a patient that has a very rapid onset neurologic deterioration, and all the exams were pretty normal, except for the CSF that was showing, that was indicating a high protein with leukocytosis and neutrophilia, with a little like red blood cell count high, and the antibodies against the gangliosides, IgG, was positive. So they started ruling out some possible viruses and bacteria and fungi, and the CSF was negative for all of these tests, for SARS-CoV, for influenza, for bacterial organisms, Listeria monocytogenes, Escherichia, herpes simplex, varicella zoster, cryptococcus, cytomegalovirus, and enterovirus, West Nile virus, just ruling out some other infectious possibilities of this finding in the CSF. So then we say, okay, we are having some antibodies against our gangliosides, and this could be the cause of the weakness. So they made an electromyography, and the electromyography showed or indicated that the patient was cursing with an acute axonal motor neuropathy, also known as AMAN or AMAN, and that was affecting upper and lower limbs with a sparing of the sensory nerve conduction. So the sensory nerves were spared. They were not being affected by these antibodies, just the motor nerves. They are not demyelinating findings. So the antibodies, no, they weren't attacking the myelin sheath. This was not consistent with the acute inflammatory demyelinating polyneuropathy that we were thinking before at the beginning. That was one of our differential diagnoses. So because they were not demyelinating process. This is the electromyography of the patient. So we can see that it's affecting just the motor nerves. So I'm going to talk about a little bit about the acute motor axonal neuropathy, AMAN, that is getting common nowadays. And it's very curious because sometimes we think that just Guillain-Barre is like the only classic presentation, but no, this is AMAN is a pure motor variant or a subtype of Guillain-Barre syndrome. So Guillain-Barre syndrome is like the leader or the great name, but we have some subtypes, and AMAN is one of those subtypes. It's the most common subtype of Guillain-Barre. So it's at 65% of cases. And it's getting prevalent in Asian countries like Japan and China, but also in Mexico. Our patient was from Central America. So Mexico is from Central America. And it is very associated with a previous infection by Campylobacter jejuni. So what is AMAN? So AMAN is an antibody-mediated attack. So we have, as I said, antibodies attacking our gangliosides. But those gangliosides are found in the axonal. So the axonal is the axon or the long part of the neuron. And this is where our antibodies are going to get bind. So AMAN is a paralytic disorder with a very rapidly and abrupt onset characterized pathologically by motor nerve fibers degeneration, and can be it can vary, or it change between one patient and the other. Like the severity can be very variable. And here we are not going to have sensory fibers attack or degenerated. This is pretty. This condition is very associated with the GM1 ganglioside epitopes antibodies. So these are going to attack selectively, as I said, the axonema of the large motor fibers, and with hours and days, weeks. Some studies are saying that at least 4 weeks they can cause a very high and huge motor axonal loss. It's like massive. So what is going to happen? So the antibodies against the gangliosides are going to attack the axonema. I'm going to tell you more in detail in which part of the axonema. But this is going to cause a complement activation, the complement C3, CD, and the complement attack-mediated membrane. And finally, they're going to, this complement activation is going to recruit some macrophages. The macrophages are going to try to clean the scene, to clean what is going on, the damage of the axons. But this clean or this try of repairment is going to worse the condition, because they're going to get rid of the axons. So the macrophages are going to do the final job, like the work. They are going to kill the axons completely, because they are going to try to get rid of these antibodies and this inflammation. As I mentioned, they are not going to cause demyelination, so they are not attacking the myelin. And these antibodies are detected in 50-60% of our AMAN patients. Not detecting the antibodies doesn't rule out the disease. So, okay, over here, we have our neuron, and you can see that this is the central nervous system and this is the peripheral nervous system. So we have this is our axon, and inside of the axon, we have the axonema that is all this way all down. And they are going to, our axon is going to be covered by the Schwann cells. But between every cells, we are going to have a node of Rainbeers. Right here, node of Rainbeers. And that is going to, and some internodes and node of Rainbeers. So this is important, because we have a lot of gangliosides in our central nervous system. But that GM1 type of gangliosides is enriched in nodes of Rainbeers and the internodes, not in the other part of the Schwann cells or the neuron by itself. No, just here in the node of Rainbeer and in the internodes, we are going to find a lot of GM1 gangliosides. So probably that is one of the reasons why this type of antibody is just going to cause this type of presentation, motor weakness, and no sensory. So over here we have a case of a patient that the first 4 images are showing how the antibodies are attacking the node of Rainbeer, are getting bind to these node of Rainbeers, like 1 and 2. So here they are stained, the antibodies are getting stained. And this E to H, we are staining the macrophages. So this is a macrophage. macrophage. Here is, we are studying the MHC histocompatibility molecular of the macrophage. So we are seeing that after the antibodies are attacking the node of Rainbow, then the macrophages are coming and are getting rid of this inflammation, are trying to repair what is going, coursing or what is going on here, but they're going to get rid of the axon that is our axon, and that's why it is an autoimmune disease. This is the same image but with color, so you can see beautiful here the macrophage, and or here are the antibodies. So I was explaining why these gangliosides are important, or why these antibodies are attacking our central nervous system, and know why, I don't know, our retina or the cranial nerves. So the gangliosides are a sialic acid containing glycolipids and are highly found in the nervous system. But we have different wide variety of gangliosides. GM1, GD1B, GD1AB, GT, and abundant. There are a lot. But we have kind of specific gangliosides in some parts of the central nervous system and peripheral nervous system. So the GM1 and the GD are localized, very enriched in the nodal rainbow and in the motor nerve terminals. And the gangliosides are part of our receptors. So if you can see, this is the integrin complex, this is the GM1 antibody, and they are just being part of the signaling process. So when a ligand is going to bind to a receptor, the GM1 or the gangliosides are part of this connection, or this receptor ligand interconnection, so we can have a signal within our neuron. So they are so important for the central nervous system. So they are, we are enriched in gangliosides in our central nervous system. So the antibodies binds predominantly to those nodes of Ramirez, the antibodies that I mentioned, the GM1 antibodies, and they can block. So we don't have clear why or the mechanism of action of these antibodies, how they attack and destroy, but there are some hypotheses. So they can bind and cause dissolution of the axonal cytoskeletal architecture, and also can disrupt the nodal and paranodal channels. So as I mentioned in the previous slide, they are part of the channels. So if the antibody is binding to the ganglioside that is part of the channel, so the channel is not going to work anymore. So that's going to destabilize the membrane. There is not going to be a potential of action, and if there is no potential of action, the neuron is going to cause axonal degeneration, is going to die. So here is important to explain something. Campylobacter jejuni is a gram-negative bacteria, enteropathogen, that it doesn't form spores, but is the worldwide cause of diarrhea. Is the most common cause of diarrhea or gastroenteritis worldwide. And so unfortunately, Campylobacter jejuni has some oligosaccharide and liposaccharides in its cell membrane that have gangliosides, that have this type of gangliosides. And when we are trying to get rid of the infection, the antibodies, infection over here, the antigen presenting cell is going to detect infection. They are going to present the epitope to the T cells. The T cells are going to get activated. They're going to release cytokines. They're going to activate B cells. But also these T cells activated, they're going to go to other parts of our body, because we are going to have memory cells. So let's say we are going to get rid of the infection, but we already have some B cells and T cells that have a memory for this infection. But the problem is that when they pass the blood-brain barrier, these T cells can say, hey, wait a moment, we have the same infection here, or they're not gonna think, or is our body? No, just we continue with the infection, but the infection is in another site. So they're going to recruit some other macrophages. The other macrophages are going to release chemokines. They're going to activate other T cells, and they're going to go against the node of Reinberg, the macrophages, and are going to get to the gangliosides that are located in the node of Reinberg. And there is a cycle. So antibodies bind to the node of Reinberg. They're going to recruit more T cells, more macrophages, and it's going to boost, increase, exacerbate this inflammation and this cell damage. Okay. Here is the same, but in color. I like to put it like in the real case and in color. But here is the same. So we have the capillary unit, immune response, antibody production. We have ganglioside mimicry. So in the axonal or the outer membrane, so it depends of the gangliosides that this Campylobacter jejuni are expressing. And then we have the two types. This is Guillain-Barre, that is the like the sensory and motor deterioration. So the antibodies are going to target the Schwann cells. But here in AMAN, we are going to target only just the node of Reinberg. And so we are going to cause damage of the axon. And this is going to cause just the isolated motor weakness, not sensory as here. And finally, so this is a very challenging condition because it's getting common, but we don't have so many studies about it. It's very sad because it's very rapid. It has a very rapid progression and deterioration. So many patients can have very vast neurologic deficits. Sometimes the patient can die. Sometimes the patient cannot recover completely. And sometimes the patients are having some sequelae, very notorious motor sequelae. So it's something that we should pay attention to highly research or investigate more about it. So far the treatment and the outcomes, as I said, the gold standard is the intravenous immunoglobulin therapy. So this is the immunoglobulin that we are going to give to the patient. And there are so many mechanisms this immunoglobulin is going to help our patient. But the most important is to neutralize those antibodies against the gangliosides. So they are going to attach these antibodies, and so these antibodies are not going to bind anymore the node of Reinberg. And that's like the way how it works. Plasma exchange is ideal, but it has to be done within the first 2 weeks of the disease. Sometimes it has, of course, as any therapy, the intravenous immunoglobulin and the plasma exchange, we are going to have so many side effects. So we have to explain to the patient what are those side effects, including prion disease. I don't know if you have heard of prion disease, but that's one of the principal like side effects that a patient can have with the plasma exchange. So we are going to we are trying to have a better treatment for those patients, but there are some unfortunate side effects that cannot happen. And there is an important thing: we cannot give steroids. They are not effective, and they can be harmful. So no steroids. People think, okay, just the patient has something, probably a transverse myelitis, or no, we have to give a steroid because it's an inflammation. No, we have to pay attention to that because it can deteriorate the condition of the patient. This is my presentation. Thank you so much for listening to me. I don't know if you have any questions.
Thank you, Isabella.